Counselling and assisted reproduction. When, why, and by whom should it be offered? The hashtag is #PetFertCounselling, and this event has been made possible thanks to the generous support of the Scottish Government. I'm Sarah Norcross, Director of PET, and I'll be chairing the discussion. But before we go to our panel of speakers, I thought it might be helpful to have a little bit of background and actually to share some of the issues that we've been having here at PET. So I think it's no surprise to people that many who have fertility treatment find it difficult, both physically and emotionally. And different types of counselling may be sought, offered, recommended, or required in relation to fertility treatment. And the language around such counselling can sometimes be confusing, leading to mismatched expectations of what counselling entails and who is best placed to deliver or to facilitate it. Words seem to be crucially important when it comes to counselling, more important than perhaps I'd thought until we started to sort of drill down into it for this event. And I have to confess, I found it, harder really than talking about, say, law and regulation in relation to surrogacy, or even a sensitive subject like miscarriage, to get the words, the sort of terms right. So I suppose first there's the sort of getting your head round what's necessary, what should be required, what must be provided or offered in terms of counselling. And then layered on top of that is trying to understand what counselling is, because it seems to mean different things to different people in different contexts. And then so there's information counselling that we hear about, there's therapeutic counselling, and then there's implications counselling, and those seem to be the three main strands, but there's probably ones I don't even know about, and I have to hold my hands up and say, as I said, we've struggled with some of the wording, particularly when trying to explain in something that could probably be put on Twitter what implications counselling is. And so PET are extremely grateful for some of the conversations that we've had with the British Infertility Counselling Association, BICA, this week, who've helped us to modify some of our wording to make it a bit sharper. And so we changed as a result of that how we are sort of, implications counselling in a nutshell terminology to define implications counselling as this involves the provision or clarification of information about the implications of treatment or donation, and also involves exploring these implications. So anyway, but the speakers will be talking much more about this and at much greater length. And I also wanted to trail that BICA is in the process of developing policy guidelines for delivering implications counselling. They're in loft form, and hopefully they'll be out before too long. But also, I think one of the big questions, it seems to me, for those who work in fertility clinics must be what counselling is necessary in order for consent to be valid, because people have got to understand what they're doing, one would imagine. Anyway, this isn't my problem because I'm not speaking and nor do I work in a fertility clinic. But we have a great lineup of speakers with different perspectives for you who will explore the different aspects of counselling and discuss how these distinctions might be clarified for you. So we have Alison McTavish, Angela Park, Lee Noquet, and Professor Jacky Boivin. So it gives me great pleasure now to introduce this evening's first speaker, Alison McTavish. Alison is a member of the Human Fertilisation and Embryology Authority. She is a trustee of PET and a trustee at the British Fertility Society. Alison co-founded Aberdeen Fertility Centre and the Senior Infertility Nurse Group. So she's extremely experienced, and I'm looking forward to hearing her presentation now.
So thank you very much for inviting me to speak this evening. And as you say, I'm speaking as a member of the Human Fertilisation and Embryology Authority. And I think I've got let's just say the starting of the meeting, looking at the Act and the HFEA Code of Practice. And I've been asked to speak about when should counselling be offered. What does the Human Fertilisation and Embryology Act, which is actually in desperate need of updating and modernising, say about counselling? It states that women shall not be provided with treatment unless she and her partner has been given a suitable opportunity to receive proper counselling about the implications of the treatment offered. Now, Sarah, I think you started us off very well by speaking about language and words like the suitable opportunity, proper counselling and implications in the very first slide that I'm presenting. I hope is going to be fully explored throughout the evening. Anyway, the legal requirements within the Act are translated into licence conditions which centres must meet to obtain and retain their HFA licence. This section of the Act is within Licence Condition 60, and it clearly states that a woman must not be provided with treatment services using embryos or donated gametes. And I'm just going to say donated gametes is eggs or sperm, unless she and any partner have been given a suitable opportunity to receive proper counselling about the implications of the treatment. The next part of the Act relating to counselling is around a woman being treated with an intended second parent. And in the Act there's reference to fatherhood, but this has been updated to intended second parent. And further in Schedule 3, and I'm not going to be quoting the Act for much longer, so stick with me, please. It states that before a person gives consent or renews consent, they must be given an opportunity to receive proper counselling about the implications of taking the proposed step. So when should counselling be offered? Within the Code of Practice, there is quite a list of when this should be, and it starts off with when donated embryos or donated gametes are being provided for treatment, or when embryos are being created for a couple's own treatment. In the current Code of Practice, it states an individual or couple seeking to store their gametes or embryos should also be provided or offered counselling. There has been an updated Code of Practice which the authority has signed off on. However, it is still sitting with the Department of Health and Social Care to update this part of the code to say that counselling must now be offered before any consent is renewed. For those working in centres completing the consent form, that information is already on the consent form that patients must sign. So counselling should also be offered prior to donating sperm, eggs or embryos for the treatment of others, or whether an individual wishes to donate their sperm or eggs for use in non-medical fertility services, or for research purposes, or for training. Because counselling should also be offered when an individual seeks to provide their gametes or cells for any research purposes. And rather strangely, in the Code of Practice, it refers to women providing embryos obtained by lavage. I'm not sure how often that actually happens. And then it's also when a notice is served by a man or a woman consented to being the man being treated as the legal father or parent of any child being born, or by a woman or her female partner consenting to the partner being treated as a legal parent of any child. That's a lot of information to take in just sitting here on a Wednesday sunny evening, but it is clearly defined within the Code of Practice, and that's available on the HFA website. For those working in centres, it's the Bible, and I'm sure it's referred to at least once a day for one reason or another. Now, Sarah also mentioned the different types of counselling that can be offered. And you'll be pleased to know I'm not going to speak about therapeutic or implication counselling because Angela, our next speaker, is going to speak about that. But the other type of counselling that's been referred to recently is information counselling. Now, there is no mention of information counselling in the Act or the Code of Practice. However, in the Code of Practice, there are statements relating to the provision of information, and it clearly states that the provision of counselling should be clearly distinguished from the provision of information which is required before obtaining consent or providing treatment. And it also clearly states that centres must provide information and offer counselling for people about the implications of treatment. Centres should ensure that all patients are prepared for treatment. Preparation for treatment includes the provision of information, the discussion of the implications involved, and the offer of counselling. So what happens in reality? The HFE patient survey in 2021 found that 3/4 of patients said that the availability of counselling had been clearly communicated to them. 76% sounds quite a good percentage, but that actually means that 24% did not have the availability clearly communicated to them, which is not a great statistic. And furthermore, fewer than 2/3 of patients, only 62%, were satisfied with the level of support given. On the HFE website, you'll find full information about this survey. Fertility Network UK survey, the far-reaching trauma of infertility, which was undertaken last year, showed that 78% would have liked to have counselling if it was free, which is a huge number of patients. Half of the respondents did have counselling, but most of these had to fund some of it themselves. And again, there's a reference for further information here. The HFE also provide further guidance regarding counselling and patient support. With regard to counselling, the HFE guidance is that treatment centres should ensure that at least one individual is appointed to fulfil the role of counsellor. And all counsellors should have specialist competence in infertility counselling and hold a recognised counselling, clinical psychology, counselling psychology, or psychotherapy qualification to the level of diploma or higher education or above. And I believe Jacky Boivin will be picking this up in her discussion. And that one counsellor should be accredited under the scheme of the British Infertility Counselling Association, VICA, which Sarah has already alluded to, or show evidence of working towards such accreditation. Furthermore, with regard to patient support, the HFA guidance is that the centre should develop a patient support policy to outline how the centre ensures that patients, donors and their partners, where applicable, receive appropriate psychosocial support from all staff they encounter before, during and after treatment. So to sum up, which I think I'm within my 10 minutes, I'm rather scared to say around timekeeping. The fertility, all HFE licensed centres must, and this is where wording is really important, offer patients an opportunity to receive proper counselling about the implications of treatment services being provided. And emotional support. There are lots of different support groups for patients, and you can find out more on the HFE website, Getting Emotional Support. I realise this is a bit of a whistle-stop tour through the Act and the Code of Practice relating to when counselling should be provided, and I think I've slipped a little bit into what counselling should be provided, but hopefully I've set the scene for the rest of the speakers.
Next, we have Angela Park, who is Fertility Counsellor at Aberdeen Fertility Centre. And so we'll be hearing now from the Fertility Counsellor's perspective about some of these issues.
Thank you for that introduction, and thank you for inviting me to participate in this webinar this evening. I wanted to just maybe start by acknowledging the fact that obviously clinics vary greatly. There's a huge landscape of difference throughout the whole country. There's private clinics, there's NHS clinics, Some patients will have to pay for counselling, some patients will not. Some clinics may have to have a cap on the number of sessions that they can afford patients. So it is a very kind of different landscape, and I think we have to just maybe hold that in mind when we're talking about this. But I would like to maybe just follow on from Alison's presentation. I'm going to start, I'm going to bombard you with more stats, but just to kind of fit with what Alison spoke of, I think it's maybe quite helpful to look at the kind of context of psychological support when we're thinking about a counsellor's role in a fertility clinic, because obviously that's the kind of bedrock of what we do. So these two different surveys, for me anyway, really stand out. You'll all, I'm sure many of you will be familiar with Fertility Network UK, their survey some years ago now, but really kind of hard-hitting numbers. 90% of respondents reported feeling depressed as a result of their fertility situation or going through treatment. 42% reported feeling suicidal. 75% would have liked counselling had it been available free of charge, and in that particular survey, over half were paying for some aspect of their treatment. A more recent survey that was undertaken and available to us last year by Ferring and Cardiff University, again a very similar theme in terms of 60% believe that fertility diagnosis and treatment has impacted their mental health, with 1 in 3 reporting a relationship strain. Less than half sought mental health support during treatment, and again we might have a lot of questions about why that was. But this survey concluded, one of the many conclusions, that a gap clearly exists between patients experiencing poor mental health and those seeking help. So I'm going to talk a little bit more now about what a counsellor's remit is. So as Alison alluded to, I think it was probably about 4 years ago, the HFEA asked all clinics, be they private or NHS, to document how emotional care and psychological support is offered to patients. We commonly call that an SOP. I'm sure that's language that we're familiar with being in clinics. So that policy should be available in all clinics, and it should detail who, when, how and what is offered. And as Alison pointed out, it's not just the responsibility, obviously, of the counsellor. Every member of staff in the clinic should be aware of what their role and responsibility is in terms of delivering patient care, in terms of emotional and psychological care. So in terms of where the counsellor sits in that, that's something that we have to pay attention to. We have to make review regularly. We seek patient feedback. We're wanting to kind of listen to that and make amendments to that. Another really important part, of course, that counsellors will have as part of their remit is to offer training to colleagues. Now, commonly that might be things like breaking bad news, effective communication, managing challenging communication. That's the kind of nature of some of the training that I've been asked to deliver. I've also written there supporting clinic practice, and what I mean by that is, we can sometimes be approached from our clinical colleagues and asked if we could maybe comment on a forthcoming piece of communication. Letters, for example, that are maybe going out to patients. Could you cast your eye over it? Does it sound okay? Is it coming from a kind of empathic place? And I think that's a lovely example of how we can work together in a clinic. And it's all about just thinking about the patient's experience with us and offering the kind of compassion and care, and just thinking about how we interact and communicate and so on. Obviously, the bedrock of what a counsellor does is deliver counselling, and as Alison spoke to earlier, there are two different components to that: therapeutic counselling and implications counselling. Now, I know Lee is going to go into a lot more depth, as is Jacky, on this as well, but just kind of what's the difference between those things? Therapeutic counselling is what you might call a relationship with patients and counsellors. It's very much a patient choice to engage with therapeutic counselling. No one would ever be forced to engage with that. It's what people would traditionally think of when they think of counselling. It's a relationship, it's time and it's regular space together to share, unpack, explore, understand what's happening in your life when you're going through treatment. It's looking at coping mechanisms. There might be a lot of other things that come into this. So it's a very important part of a counsellor's work. I would say that typically I maybe spend about maybe 70% of my appointments every week will be on therapeutic counselling. Implications counselling is different in that I've written down on that bubble, it's often mandatory. I think it's a little bit of a grey area. Some clinics will make sure that it is mandatory and that anyone considering becoming a donor or using donor gametes or entering into a surrogacy arrangement, treatment wouldn't proceed unless they have had implications counselling. That might be, I think it's a minimum of 2 sessions that BICA recommends. But the whole point of implications counselling is to enable an informed decision-making process for the patient. Is this pathway ahead right for me? It's slightly different for a counsellor in so much as we're much more actively raising questions, putting scenarios about the short, medium and long term of using a donor or being a donor or having a surrogacy arrangement. But it is very much part of a counsellor's remit. And as I say, that probably takes maybe, in my circumstance, maybe about 30% of my time with that. So that's the kind of, I hope, maybe the sort of wider where we sit in a clinic, as well as our core work. But in terms of kind of knowledge, understanding, our toolkit, as it were, it kind of goes without saying that we have to have a very, very sound knowledge of assisted reproduction technologies. The investigations, the treatment pathways, protocol, medication, the language, we've kind of mentioned that earlier on, but keeping on top of research as well. So having a very kind of clear idea of what the medical system is all about, what's happening. Maybe some of you who are listening or watching this evening might recognise when I say my experience of patients are very, very knowledgeable. They do a great deal of research. You know, there's a lot out there online. There's a lot of groups. So I think we have to really respect that, and we have to also be continually keeping, on top of what's out there, watching webinars and so on, listening to, reading articles about the whole kind of medical side of this. It obviously goes without saying that we have to have an extremely strong understanding of the emotional impact of fertility issues, trying to conceive, and involuntary childlessness. And obviously what goes with that is the kind of underpinning the theoretical approaches and the techniques that we use to work with patients, to work with our clients. There's a lot around grief and loss, about identity, about living in an unknown. So we have to have a fairly kind of deep and extensive toolkit that we use to work with this client group, going through what they are. Alison, I think you referred to the Code of Practice, HFEA and BICA guidelines as the Bibles, and I'm absolutely with you on that. I don't know if I look at them every day, but certainly it's probably a weekly occurrence. Fantastic resource in terms of they state very clearly what we need to do, when, how. Great reference point in terms of quality standards and so on. Support organisations, there are so many invaluable ones out there. I've just picked up a very small handful there: Fertility Network UK, Donor Conception Network, Seed Trust, SANS, MISCA, so on. There's so many out there. I greatly value being able to watch webinars, listen to podcasts, engage with training that these many organisations offer and run. And so often as well, it's a great way of kind of sharing with patients and disseminating information. So, you know, there's a huge amount of information out there, and it's a very dynamic sector to work in and be in, which makes it very interesting and very exciting. So I hope that maybe gives you a kind of insight into what the remit of a fertility counsellor is. I very much hope you found it interesting, and I look forward to engaging with questions and having discussions at the end of the webinar.
Next up this evening, we have Lee Noquet, and Lee is the egg donor coordinator at the Edinburgh Fertility Centre, and she's also a fertility nurse.
So my remit is to discuss with you this evening about counselling and when fertility treatment involves a donor. So I'm going to start off by framing my talk with this image, which is the School for Athens. This image was painted by Raphael, and it adorns the walls of the Vatican City. I'm using this image, it's a fictional representation of a meeting of minds, and it's a gathering of some of the world's greatest thinkers, from mathematics to philosophers and scientists, and it's where art and science come together as one. They say it takes a village to raise a child. Well, it takes the concerted efforts of the entire multidisciplinary team to create or help and assist in the creation of one. So, who may require implications counselling? Indications for gamete donation indications for gamete donation is a group of people where there may be an absence of gametes, or there may be a medical need. So heterosexual couples, same-sex couples, trans folk, solo parents, and surrogates. Whilst the surrogates will be the recipient of the embryo, they won't be the parents that will bring the child up. So gamete providers come from sperm donors, egg donors, and embryo donors. Never has there been a better time when there is more choice and options available to individuals and couples on how we create a family. And these landscapes lead to very complex relationships, and it's why implications counselling is paramount. Fertility services have changed the way they deliver their services and need to be inclusive, equitable and fair and fit for purpose, as modern families are differing in so many ways. Unfortunately, however, it is still a bit of a postcode lottery as to who in the UK can access NHS funding, and therefore some people can only seek treatment by paying for their treatment. So what is implications counselling? I think my colleagues have done a very good, great job of explaining what implications counselling is, and I've taken also from the Code of Practice a suitable opportunity to receive proper counselling about implications and the treatment provided. I've also taken from the Royal College of Nursing, implications counselling is the provision of information to ensure that persons understand the processes, the risks, and that are associated when undergoing treatment. And counselling provides, according to Beaker, provides you with a chance to talk about your feelings, experiences in a safe place with someone who will listen and support you. Your counsellor will seek to understand, not judge, and will work with you to make sense of the situation and make changes that will improve your life. And I think there is a lot of tension in the word counselling, and this sometimes when you're trying to encourage people to take up counselling, they find the word counselling, it can be challenging for them. So as a nurse and part of our medical team, the doctors and consultants that we work with, we are all responsible for providing information to ensure that a person understands, and we are always discussing risks. And this is very objective information that we are discussing with our patients, whereas the counselling with the facts, with the understanding of the responsibility, will give the patients a chance to explore feelings and thoughts around their treatment and to decide whether the treatment is right for you. Because implications counselling is not a given that the person that's receiving the implications will even move forward with counselling. Sometimes you need the information to know or understand whether this treatment is for you. So in order to show the patient journey, I've used Kubler-Ross's change curve. And this was originally used for patients that were diagnosed with a terminal illness who wanted to demonstrate the journey that they went through. So you can see the roller coaster of emotions that go on, and I'm using this apply to infertility counselling. So down on the left, we have morale and confidence, and at the bottom, across the bottom, there is the time it takes. So starting with shock, our patients come for treatment and they may embark on IVF treatment and have treatment and then later find that that treatment has been unsuccessful and there's a problem with the gametes which causes them to need implications. So those patients are certainly in shock. Other patients, such as same-sex male couples or female couples or trans folk, may have already experienced these sort of feelings much earlier on in their journey and are resigned to the fact that the only way for them to start a family is to seek donor treatment. So the feeling of shock is about how is this possible? How did I arrive at this place? And then moves through to thoughts and feelings around denial. This isn't happening. This isn't me. This isn't where I want to be. Moving down to thoughts of frustration. Why me? Why us? And this can lead to low mood, depressive thoughts, and as we've seen from the earlier presentations, suicidal ideologies or intent. All of this is information and supportive counselling. And many of our patients have already engaged with counselling or will be offered the opportunity to engage with counselling in order to work through this roller coaster ride. Once a patient has decided that they want to embark on treatment or is thinking about it, they might need more information in order to see how this sits and feels for them. This is the experimental phase, and this is really the beginning of where implications counselling starts in clinic. Once they've asked questions, been provided with information from their doctors, from their nurses, and from the counselling support they've already engaged in, they move on to decision making. How do we feel about this? Now, sometimes this can lead to incongruence between a couple, how we feel about this. It is a very individual situation and impacts people think and feel freely in different ways. And sometimes this can lead to conflict in a relationship. However, you hope that with the support of the counselling service and backed up with it, but the information and the facts of the science around the treatment, that people will decide and eventually arrive at a point of acceptance. Now, acceptance isn't necessarily that they want to embark on treatment. It could be that they have decided they don't want to embark on treatment. And all of this counselling here for implications also applies to anybody that might apply to become a donor or a surrogate or is thinking about that. And we always feel in our clinic that the success of this, if somebody says they don't want to do something, it shows that they have really been provided with the right support and the counselling to accept this. So in my next slide, they say an image can say 1,000 words, and with only 10 minutes to speak to you, I thought I would try and bring an image together which would lead to some thoughts and ideas. So these relationships are complex. They're lifelong, with lifelong implications if successful. On the one hand, you have the donors, and the donors, how they relate within their own family and how their family and their children and parents, grandparents and friends relate to them offering their donor gametes. And they may also be siblings of a recipient or intended parent or a close friend, and how that interrelationship is going to work in the future. So in clinic, we are looking through this very narrow lens of something that is much wider in the life and relationships of the people that are involved in it. So I've put the donor conceived person because they won't just be a donor conceived child, they'll grow and become an adult with their own thoughts and feelings around the world, around in the world. So the donor conceived person is here, the clinic treatment is here, and there's so much more wider impacts of that in the wider area. And recipients might commission a surrogate, and that surrogate might be known to them, or it might be somebody that they have become to know through an organisation such as Surrogacy UK. So recipients also may have children from a previous relationship. They also have families, wider families and friends that might be affected by the donor conceived child. And we can't ever plan for what will happen in the future. So future relationships for the donor conceived child from self and others. What if the relationship breaks down? What if there is an early reveal in an unknown donor situation? All these thoughts and feelings have to be gathered in and discussed in the counselling room or in our clinics. So in conclusion, what I'm about to say is that approaching implications counselling is complex. Gamete donation is complex. It's much more mosaic rather than a linear process. Implications counselling is the responsibility of us all within the multidisciplinary team, with the counsellor playing an essential and pivotal role in the process. Donor conceived person should be at the heart of the process. Any treatment is as individual as those who are involved and adapted to meet the needs of each person involved. And we should think about the pace and time at which people experience their journey. The provision of accurate information and understanding is a key component of informed consent. The language we use, the terminology we use in clinic and in our counselling rooms is very important, as we should not seek to alienate or cause any unnecessary distress to our patients. Implications of donation are not only affect, do not only affect those participants. We should give additional consideration to those persons whom are hidden from our view. So these are the references I used and some very valuable support services that are also available.
And then we'll move on to our final speaker, Professor Jacky Boivin. And Jacky is a Professor of Health Psychology at Cardiff University's School of Psychology, where she also has, I must ask her about this properly one time, another role in relation to being a lead researcher at Cardiff in fertility studies. And Jacky has written lots about the history of fertility-related counselling and has developed a conceptual model of infertility prevention. But at our event last week, actually, your research was quoted in a very different event.
So I was asked to talk on the topic of what is counselling and whom should it be, by whom should it be delivered. So I think we've had such a great intro from all the previous speakers that my job is a little bit is made a little bit easier by pointing out some of the issues that we have with thinking about counseling in the context of infertility. First of all, we have legislation that gives us guidance that we need to provide a suitable opportunity to receive proper counselling. But the Act itself gives minimal information about what counselling should comprise and does not really stipulate who should provide that counselling. For that, we look to the code of practice that the HFEA has been developing over years and years. And what we have here is an interpretation of the meaning of the word proper counselling, and that changes over time. So here are some of the changes. Now, I didn't go back too far. I went back to the first reference to implication support and therapeutic that I could download, if you will, from the internet, which was 2003, 6th edition. Now, we have two things that we have to keep in mind. What is the nature of counseling and who is the provider of counseling when we look at the HFEA code of practice? Because in a way, the code of practice represents our the evolution or the change, normative ideas, the what clinics in general think, what the population may think, and so on, the public, etc. So in the 2003 edition, there's a differentiation, say, between routine counsel that doctors would give to their patients about treatment or any other advice they might give in the process of a consultation, separated from the implications. And the implications usually refers to the implications of taking a particular course of action, supportive counseling and therapeutic counseling. And the people who were considered to provide the counseling were, of course, doctors to some extent, but also people who had a higher education degree in some form of psychology or qualification for psychosocial care, essentially. And at the time, there were various different qualifications, and also recognition that they had to be a member of recognized professional counseling body. Years later, we get into the 7th edition. We still have this differentiation of implication, support, and therapeutic, but there's a little bit more division on the implications. And to address what potentially is here, implications of treatment versus implications of donated material. And the person who can provide that is more or less the same. But there's a new addition, which is that if in the case of egg sharing, there needs to be follow-up BICA guidance, and BICA being the British Infertility Counselling Association, which people have referred to before. Now, the 2009, which is the 8th edition, and bear in mind that it was revised yearly between 2010 and 2017. So there are lots of different changes over time. Here, it refers to counseling in a generic way, implications of treatment again, implications of donated material, but it's dropped this support and therapeutic element. And it comes back to a kind of more routine counsel provision of information. So counseling exists as a word. These two implications are differentiated, and again, differentiation of this kind of more routine counseling. And now we have some drops in the type of people who can provide this, but some balancing, if you will, so that people have to have the higher education diploma, and they have to be working towards BICA accreditation or an equivalent, and they have to be a member of a professional body, and they also have to have specialist competence in infertility counseling. Now, in 2019, and then again revised in 2021, we have these different versions now. We have patient support, implication counseling is more implication discussion, and we have specialized psychosocial care referred to as infertility counseling. And we have some more additions here, which now is that if a generic counselor is appointed, then it needs to be accredited by BICA or equivalent. And this is important to mention because previously someone said only BICA could accredit, but it's or equivalent within 2 years. Now, why am I highlighting all these differences? Is this just, nitpicking? Well, the answer is no, because potentially it has some implications. And they're alluded to in the HFEA code of practice, but they're not as issues discussed that we need to discuss, I think. So in terms of the nature of counselling, what seems to be one of the big issues is who can talk about the implications of a course of action. And one of the reasons for that is because implications could be just medical implications, but they could often involve, as was very well described by the previous speaker, Lee, could involve many psychosocial issues, many emotional issues, and so on. And then we have the counseling, which we could just think about as counseling about the psychosocial needs, say. So even if we ignore implications for a minute and think about psychosocial needs, already there we also have two divisions: the kind of patient-centered care that we think that everyone within the clinic can provide versus this more specialized therapeutic care. So these things seem to be the things that we see oscillate and change within the nature of counseling across time. And then the provider of counseling, so there are differences sometimes, or there is that medical professionals specialized, i.e. that they have the right knowledge of, for example, donation, can provide implications counseling, but it's recommended that actually that specialized psychosocial professionals be used because of these issues that arise over here. So the two things are acceptable, but there's a preference maybe for this. Then there's the provider of counselor. Who is the provider of counselor that is suitable for a fertility clinic? And here we have, it's the code of practice is very counselor centric, if you will, in that a range of professionals could potentially provide this: psychiatrists, psychologists, name other professionals, social workers, for example. But there's a tendency towards more taking a counseling approach, and that's just one of the disciplines within psychology. And then finally, there's also a kind of confounding when you look at the kind of changes between domain expertise, so that, for example, in the term infertility counselor, there's a confounding between the expertise that people have because they know a lot about infertility or third-party reproduction or services offered in a fertility clinic versus a particular therapeutic approach, which is counseling. And so we could have called it infertility psychology or infertility psychiatry or infertility, but the word is infertility counseling. And of course that happens because the Act says proper counseling, but did the Act mean proper counseling, i.e. only this subdiscipline can manage these work? Now, we have to really think about these issues because these issues also have an impact on who could be a provider. And I put my CV here. I have all the qualifications you can imagine to be a psychologist, to deliver psychosocial care, to be an expert in this topic area, to have influence in many, many different areas, and also to be head of a department, deputy head of a department that has a lot of clinical programs. I could not meet the requirements as they are in the code of practice. And none of my students who are highly qualified practitioners could meet that. And so I think one of the things that we have to discuss to some extent is, in addition to when we compare implications versus psychosocial counseling, is who are the cadre of professionals that could be delivering this kind of care?
There was a question which is not the most popular question, but it's solicited the most popular answer, I think. So we had a question from an anonymous attendee saying, should people who are not counsellors deliver counselling in clinics? And before I go to the panel, I will just say that Anthony Ribb, who is a fertility counsellor, has said the answer to that question should be people who are not counsellors deliver it. No, no, no. I wouldn't see a dentist who's not a dentist as an example. Okay, so I think we'll perhaps go to Jacky first with that one, and then we'll go to Angela and then Lee.
I would say the person who can do the counselling is the person who is qualified to be the counsellor that's needed at that particular moment. Now, I, like with everyone else, agree that implications counselling for a course of treatment, especially when it takes, when it involves donated material, I would say the psychosocial expert is the best person to deliver that kind of counselling. Do they have to be a counsellor? I would disagree with that. I think they could be a psychologist, they could be a psychiatrist, and so on. And that's recognized in the HFEA Code of Practice. But the fact that they also have to be a member of a recognized counseling body, that they also have to have some further accreditation in infertility counseling, is to me the problem. I think they have to be experts in infertility, but I don't think they have to be experts in counseling. I think a range of other psychosocial experts are highly qualified to do all the things that have been discussed today.
Angela, what do you think?
I guess I kind of partly agree with what Jacky said there. I'm just sort of holding in my mind BICA guidelines, HFEA, Code of Practice. It depends. I mean, I suppose the context of that is everything. You know, it depends on the patient, the client, and what the nature of the counselling would be. If it's implications counselling, therapeutic counselling, I think I would feel more inclined to say that when it's therapeutic counselling, it should be a counsellor. It also raises questions about, well, if somebody is thinking they're having counselling, but it's not with a counsellor, what ethically, where does that sit? I do feel maybe more inclined to think when it's implications counselling, that you can be equipped with the active questioning that needs to happen, the scenarios that you present to patients and clients about potentially going down the road of being a donor or using donor gametes. And I would say, yeah, that doesn't always have to be a counsellor that would deliver that. But I do feel when it comes to therapeutic, that it's appropriate that it is a counsellor with a counselling diploma or similar qualification that should deliver that.
Is there anything you wanted to add there, Lee?
I was just going to say, I don't think doctors or nurses, it's their place to do the counselling, for sure. Because we have trained fertility counsellors that are BICA registered or working towards BICA registers, they are specialists in their counselling around fertility treatments. What I think I really have an issue with is there's a difference between offer and uptake. And what I would say is that the offer isn't enough for implications counselling. The uptake is important, and certainly within an NHS centre and with our centre here, it is mandatory, and we have counsellors that we refer patients to, and it's a mandatory part of the process of exploration, information and understanding for our patients, whether they're donors or whether they're recipients or intended parents.
Just to sort of follow up on that point, actually, Lee, because one of the many great things about Scotland is that you have good NHS provision and you have good connection between the NHS centres. So you're all more or less offering the same thing. Is that the same across the 4 NHS centres, that implications counselling is in effect mandatory for donor conception? And if you don't know, then perhaps Alison may do.
I think it is.
You think it is, Alison?
I think it is. I think the 4 centres, I have a process that donors and recipients are counselled before accepted for treatment.
So thanks for that. So I was going to sort of follow up on, not on that point, but on the sort of the last question really, as a comment, but perhaps Jacky wants to come on this one. So it's from Suzanne Dark, who says, seeing a counsellor carries less stigma than being told you need to see a psychologist or a psychiatrist, which implies a fault. Counsellors don't treat patients. Oh, someone's just liked something and it's messed up my list. Sorry about that. Counsellors don't treat patients. They often they offer space for exploration of plans and impact of treatment. That's in an entirely different relationship. Do you agree with what Suzanne says there, Jacky?
No, I think, to me, psychologists are trained to do all the things that were described previously, talk about their feelings and experiences in a safe place with someone who's going to listen and support you. Psychologists do all of that. But in addition, they're also, and this is contrary to the counselors, they are people who are also can work with people who have mental health disorders, such as if some patient came in with personality disorders, they have additional training in these kinds of disorders, but it's just that their approach to how they might have discussions with patients might be different because their theoretical approaches are different and their backgrounds are different. They have some overlap. So, you know, it could be that counselors also use CBT, for example, and psychologists also use CBT. We use more assessment in our approaches, but that doesn't mean that it's not it's a judgmental space. I think that's a misconception of what happens in psychology. I think they're both perfectly qualified to do this work. The difference is that you need to have whoever decides to go for the infertility counselor or the infertility psychologist, that they have the expertise in the domain.
Does anyone else want to come in on that one? I think it really was just a question for Jacky.
I was just going to make a slight little comment there, that patients come to clinic with their whole life behind them, and they arrive in our centre for fertility treatment, but they may have a whole catalogue of other issues to deal with. And I think the skill of the counsellor is to know when to keep a patient focused in implications or information regarding their fertility treatment, and when to refer on to psychologists, psychiatrists, or wherever for other issues that don't pertain, because we don't have unlimited resources and patients don't have unlimited finances to pay for treatment that's ongoing or lasts over many sessions.
But why wouldn't a psychologist be able to do that work?
I'm not saying a psychologist wouldn't be able to, but in the focus of fertility, Beaker is training counsellors in fertility specifically, and I think that they are well placed. And unless there's a change in the wording from the HFEA, I think we may not be able to seek the skills of psychology or psychiatrists, or possibly afford them.
Yes, I have to say that the affordability had crept into my mind, Lee, about this, probably particularly with I imagine a psychiatrist. Becoming quite expensive.
But there are all levels of psychologists that that would pay would be less costly. I think it's worth something exploring that at minimum.
So I think, as we're sort of talking about perhaps some of the wording here around the code of practice, there's a question from Anthony Ribb. Is the HFEA prepared to review their wording around counselling and update where it says patients should be offered counselling, and instead say something like counselling must be carried out, even to begin with in some specific scenarios? Similar to surrogacy, merely offering is quite wishy-washy and not supportive enough, in my opinion, he says. Too many times I and my counselling colleagues meet with people who are really struggling, could be after many years, many attempts, losses, and they've never met the counsellor, including those using donor gametes. Alison, I'm not going to make you tie the HFEA's hands here, but just to show that you're listening.
Thank you, Sarah.
and might take it back.
Yeah, no, I couldn't agree anymore with that statement. And in fact, the HFE, the review which I briefly mentioned, the modernisation and regulation of fertility treatment and research document that was closed actually in April. But one of the questions that was asked by the HFE is, what do people think, to what extent, and I looked it up ready for you to ask me, so I'm glad that you did. The question actually is, to what extent do you agree or disagree that the Act should require all donors and recipients to have implications counselling before starting treatment? So that was a question that was asked. I do not know what the overall response has been to that, because the HFE hands are tied, because they can only enforce what is in the Act, which is why the 2 licence conditions that I had in my presentation, that's the extent of the power of the HFE to enforce counselling. And it's only to enforce the offer of counselling, because that's the words in the Act, the same as in the Act, that the words proper counselling, which I think probably everyone in this meeting might have a slightly different definition of that. The offer of counselling is required by law, and it's only implications that's required. As Angela said, her workload is the majority is therapeutic, and implications is a small part of it. And the code has provided guidance, but the Act does not give us any powers to enforce anything. And changing the wording, actually, it was a bit of a revelation for me at the last HFE authority meeting, because we are updating the code of practice, which you think should be a fairly flexible working document, but it actually has to go to the Department of Health and be signed off by government. So changing wording is not an easy thing to do, and you can't have the word must unless it's in the Act. So unfortunately, at the moment, that's where we are. I'm sure if you want to contact the HFE, Anthony, to make your views known in response to the review document, and as I say, question 23 is the one you need to look at, that would be helpful. Thank you.
It does, yes, it does seem that there are quite a lot of, well, Anthony calls them wishy-washy, I call them weasel words around this.
Oh, Sarah, you are cruel.
No. It's the sort of what a lawyer would call them, really.
Yeah.
In terms of, you know, that, and I'm not. That's not a criticism of the HFEA, but it's because of the legislation. So, you know, we're using words like suitable and proper and
Absolutely.
offer are all things that are subject to a great deal of interpretation, which can in some situations
Not helpful.
be good because you want some flex. I think I've frozen. Am I back?
Yes.
Yes, you're back.
I'm back. In some situations, you know, can offer some flex and be helpful, but then in other situations mean that they're just routinely ignored because there's nothing of substance behind them. So I think it's you know, there's a problem, you know, a problem here that needs to be addressed. Yeah. Angela.
I was just sort of wanting to maybe offer, I think that maybe links, from my point of view, this is obviously I'm speaking to my clinic environment, that it really maybe fits with the importance of the patient SOP, emotional care policy, and the...
Just going to interrupt you there for a moment, Angela, just to say that SOP, can you just explain the acronym? Sorry, just in case people don't know.
Standard operating procedure. Sorry about that.
All right.
The document that I referenced in my presentation, and others have too, I think, Alison, the importance of having something that is a document that states how are patients cared for emotionally and psychologically, who does it, how, when, what. And I certainly think that when it comes to the kind of my colleagues, they very much buy into the counselling service is there as a fundamental part of patient care. So the offer of counselling is not just an offer. I think that there's a kind of regular, we've got that kind of embedded in our communication with patients. So the nurse team, the lab team, medical team will say pretty much in most, if not all, interactions with patients, you know, how are you? You know, you do know we've got a counselling service. Would you like to access it? This is how you can. We can make an appointment for you if you want. So the kind of offer is, it's not quite so loose, but I totally appreciate that the actual code of practice does kind of wishy-washy. I think a lot of it comes down to the colleagues in the team and the rest of the team, and their kind of buy-in to the whole counselling service as well can make such an enormous difference.
No, I think absolutely. So the next question that I'm going to go to is from Jenny Hunt, who says, given that some clinics now advise staff that egg donors do not need to receive counselling, what might the implications be in the future, since they may not have given consent that is both factually and emotionally informed? I don't know who wants to take that one first. I'll perhaps go to Lee, because she is the donor coordinator and might want to come in first on that one.
So I think from my point of view, working with donors and my experience is donors come in all shapes and sizes and at all ages. You can donate from the age of 18 up until 35, and you can be a very different place in your life in between. And so, as I said, in our centre, it's mandatory, and I feel that we are all assessing or talking with these patients, building relationships and rapport, and trying to steer them gently and carefully through the process and make sure they fully understood and thought about the choices that they're making and how their older self might look back at their younger self and feel that it was still the right decision for them. And as I said, as part of my presentation, we see it as a success when we've done the implications and had the medical appointment and a donor decides to withdraw, because we feel that they have really thought about this and they've not dived in head first. And sometimes you need to pace the appointments to allow for some quiet reflection and maybe support counselling as well as implications counselling, so that longer term view is properly thought through and that they have perhaps discussed it.
Alison.
Thanks. I think from what Jenny's saying, clinics should not be advising staff that egg donors should not receive counselling. It's very clear in the licence conditions that, and I know it's wishy-washy, but it is very clear that patients must be given a suitable opportunity to receive proper counselling about the implications of using donors. That's the only language that we can use, but it is a licence condition that the egg donor should be offered, and there should be a record of that offer within the clinic records. That's about the only thing the HFA could do as part of an inspection, pick up that egg donors are not being offered, because that would be a breach of a licence condition. Not hugely helpful, perhaps, but it is there in the Act and the code. Thank you.
Thanks, Alison. So next question is from Olivia Montuski. And Olivia says, Angela, your role at your clinic sounds as if you have a central and respected role providing support and training to staff as well as counselling patients. Sadly, this is not the situation in every clinic. Many counsellors are treated as peripheral to the main medical work of the clinic and are not listened to. Would you comment, please, on the importance of counsellors being valued members of the team? Dave, you start on that and then others might want to chip in.
Sorry, Sarah, it hung there. Is that, are you asking me to respond to that?
Yes, please.
Yeah, I didn't catch the last few seconds, but I think I got the general.
So would you comment, please, on the importance of counsellors being valued members of the team and respected within the clinic hierarchy, part of the multidisciplinary team? Yeah, absolutely. I think it's crucial, I would say, if that's not too sort of dramatic, but I think it's so important. I am very, very lucky where I work that I feel very much part of the team. I feel that they seek my professional input and advice, and they listen to mine when I have. So I am very fortunate, but I totally respect what Olivia is saying, that it is not the same. And certainly when we have national training courses and so on and so forth through DCN and BICA, you hear about what's happening elsewhere in the country, and sadly it is familiar what Olivia is describing there, but it is so important. And I don't think, I mean, it kind of starts from the high level. You know, you've got the HFEA code of practice, you've got the BICA guidelines, so from a high level, strategic level, the importance and the value placed on counselling and patient emotional care, psychological support, it's up there, it's embedded in that, even if the language is a bit wishy-washy. But without that, the people who are most going to suffer are the patients that are going through treatment over many years often. And so in many ways, if it's not regarded as being equally important to medical care, then we're on a sugary peg. So I don't know, that's a bit of a wordy answer, but I think it's so crucially important to the overall clinic performance, patient experience. But actually, we're talking about patients and clients here. These are people who are desperately wanting to have a family or to extend their family. And it means so much. And the whole process of what they have to go through in order to try and achieve that, with the knowledge it might not happen, or it might happen but they don't know when. So I think anyone that feels that that's not worthy of having space and time when patients need, it's fundamental really to patient care. And any private or NHS clinic who speaks about patient care, patient-centered care, patients, being at the forefront of care, counselling is part of that. It really has to be, otherwise, we can't really say that we're delivering in any meaningful way. Yeah, I can see a lot of nodding from Alison. Did you want to add anything there, Alison?
No, I think Angela summed it up perfectly. Obviously, I've come from the Aberdeen unit and was there for 36 years. And counselling was always part of the team and the ethos of the centre and patient care. And I think you would struggle to say you're providing patient-centred care if you don't have a counsellor fully on board and involved in, as Angela's mentioned, SOPs and working with the teams. And certainly when it came to, and I'm speaking now not as HFEA, I'm speaking as the ex-Aberdeen Centre nurse, certainly when it came to the emotional support, which the HFEA provided great guidance on, and the toolkit they provided was perfect to set up a really good standard operating procedure to involve all staff, from receptionists all the way through, as to where they were in the patient journey and how they can support patients. And I think that helped team building within the centre, as well as up in the care that patients received. And it is disappointing when I hear stories, as Olivia has mentioned, that it isn't replicated throughout the UK. And it is a challenge. I'm aware of resources and needs, but I think to have the counsellor in the centre, part of the team, is a fundamental basic need.
I could see, I think, nods as well there from while you were talking from Lee and from Jacky. So if we're all in agreement, then we'll move on to another question from Olivia. I don't normally do two on the trot from the same person, but it is a popular one. And she said, Lee has mentioned mandatory counselling for those using donated gametes and donors. I couldn't agree more, says Olivia. Would all speakers please comment on this? So I think I'll sort of, we've not heard from Jacky for a while, so I'll say to Jacky, what do you think about mandatory counselling?
Is this, sorry, I was looking for the question while you asked the question. So as I said before, I personally think that implications counselling, where especially in third party reproduction, should be mandatory, because I think there's so many implications, far-reaching across the life course, as Lee described. It's more mosaic. I like that analogy as well. I think absolutely needs to be mandatory. Psychosocial counseling, whether that's mandatory or not, I have a different perspective on that. And I think one of the most important things the HFPA has done recently is to enable patient support policy and separating that from counseling. Because what we weren't getting with the idea of offer of counseling, when it was solely just focused on offer of counseling, was that you'd have 20% of patients, and this is many studies over many years showing the uptake of counseling, about 20%. But then that meant the 80% didn't have anything. And by developing this concept of the patient support policy, many more people have access to that kind of care now. So I think that's great. Whether I would do it mandatory, you know, as psychologists, we approach this question in a slightly different way. We said, why is the uptake not 100%? And, you know, you have to respect what patients want to do. I don't think the problem, not from our research anyway, is just that they're afraid of the word counseling, or they're embarrassed, or they think it's stigma. There are a lot of other reasons. So I wouldn't make psychosocial mandatory. Unless, of course, they were referred specifically for that.
Okay. Angela, what about you? Do you think it should be mandatory?
I do. I think very much as Jacky echoed and Lee in her presentation, it's so, I mean, and you know, just that kind of in future years, thinking about if you're an 18-year-old girl, you know, when you've donated eggs, you know, a huge different stage of your life in terms of development, brain development, and so on. So I personally feel really strongly that donation and recipients, surrogacy, and so on, it should be mandatory. I think it's you would hate to think in years to come that people may greatly regret their decision. And I think it's an ethical responsibility for clinics to make sure that it's given. And there has to be questions if people strongly felt that they didn't want to engage with the counselling, what that might be about.
Yeah.
Alison, I won't come to you for this one because it might put you in a slightly embarrassing spot. Okay. Next, we have something from Ruth Wild. I think it's more of a comment, actually. It's quite long, so I'm just going to read through it. So the requirement for BICA accreditation or accreditation by an equivalent body, although there are currently no other equivalent specialist fertility counselling bodies, is to access competence to deliver the full range of functions expected of the person who fulfills the role of fertility counselling specialist in a clinic. A highly qualified accredited counsellor would face the same barrier as a counselling clinical psychologist of the needing to seek accreditation from BICA to demonstrate their specialist competence in fertility counselling. It's not about the psychosocial professional delivers the fertility counselling. Sorry, it's not about which social professional delivers the fertility counselling. It's about being able to demonstrate the competence in fertility counselling so that patients can have confidence in the professional that they are seeing. Does that answer your point about this, Jacky? Because this is sort of, I think, really is in response to something that you raised.
I think Ruth has done fantastic work, and I appreciate what she's telling me there about, I think what you're saying is, but Jacky, if you were a psychologist, you would still need to do this because that's how you achieve your competencies in working in a fertility clinic. And while I appreciate that BICA may be the holder of a lot of that knowledge of expertise, my point is about whether I need to then be accredited by a counseling body instead of the Healthcare Profession Council, which is a mandatory requirement in the code of practice. So I'm not a counselor. There's no reason why I would pay extra money to be somebody who's in a recognized counseling body. I don't think that I need to be have peer supervision, because that's not something that we do in our own work for continued accreditation. So the approaches to me being a practitioner are different from the ones that I have to follow based on my own profession, my own discipline of psychology. And so that's the thing that I think is an issue. I have to sort of switch from being a psychologist to a counselor and follow the requirements of counselors in order to practice by this standard. And I think I don't see why that is. I'm as qualified, or assuming that, the people who are going to be doing this have a higher degree in psychology or as qualified. They just need the infertility expertise, not all the other stuff that goes into the code of practice right now. And I do want to say with this that we have so many talented young psychologists who could be in pretty much every fertility clinic if they weren't burdened by this extra accreditation stuff that they don't need to practice anywhere else in cardiovascular, in cancer, in name any other areas of health. So I think that's something to think about. But thanks, Ruth. I did see what you were trying to do.
Great. Okay, I think that's a debate that will
rage on.
We continue between Jacky and Ruth offline. Did anybody else want to? Did anybody else want to come in on that? They're all keeping out of that one. Okay, so we've got Pauline Everett, who has asked a number of questions, but one of her questions has come now to the top of the list, which is, should the government tax private fertility clinics and fertility law firms to fund courses for NHS counsellors to be supported by bioethicists and infertility psychologists, which would help fertility clients understand the implications of their decisions? So, there's quite a lot to unpick in that question in terms of a special tax being introduced, not just on clinics, but on fertility law firms, to fund courses for counsellors, and also so that they can get potentially additional support. Who thinks that's a good idea? It's quite a big one. Angela, go to you first, and then perhaps Jacky.
Great idea, yes, but I can't see that flying at all, but I think it's a great idea.
Alison, you've got your hand up, go on.
Yeah, it's just from a taxation or levy of fees, for example, HFA charge fees, which goes in to support the HFA authority work, but those fees cannot be used for anything other than what they are gathered for. So you can't suddenly introduce a tax. For example, the HFA fee cannot be used to support training of counsellors. It's very strict boundaries as to what the funding can be used for. So although it's perhaps a very nice idea, I think it is a nice idea. Putting it into practice would be impossible.
And I don't think the HFEA, well, certainly currently has any levers over fertility law firms.
Absolutely not.
So I think that would be difficult. We'd have to be looking at something completely new there. Did anyone else want to come in on that one, Jacky?
So if I understood the question, I think the question is one about how can we support counselors and ethicists and whoever else we think in a multidisciplinary team environment to get the appropriate training. I mean, I think it is within the gift of the clinics to allocate time for training, but I also think that those of us who develop resources and training, such as ourselves here at Cardiff, to develop training that's free. And so people don't have to pay for that kind of training or for these additional courses. And I think that, part of it is the developers, part of the solution is the developers, and then the other part of the solution is the clinics themselves. And there should be pressure maybe from I don't know if it's possible, but from professional societies like the BFS or others regarding continuing professional development for these experts.
Yes, I think that is a good point about what the other professional bodies can do here in terms of offering support. So I think there's a comment that's come in about taxing private clinics from Sarah Denning, actually, which is taxing private clinics would drive up costs for patients, many of whom have been forced to go privately as they have NHS funding, or it could be simply they've had some NHS funding and now they want a second child and it's gone up I think. So yeah, that's a good point, Sarah, because ultimately someone pays for additional services in clinics, and it's usually patients when it comes to the private sector. So thanks for that. So I was going to go now with a question from Menno Hoffman, which is for Angela in the first instance, and he says, does implications counselling include reference to DNA sites which may make secrecy or anonymity, I suppose, impossible even more than it used to be?
Yes, it certainly does. It's obviously something that we've got no control over, so we talk in implications counselling about the kind of framework of what a child's rights are, what recipient parents are entitled to find out, what the donor is allowed to find out, and so on. But underpinning all of that is, a strong emphasis on that's all fine, but at the end of the day, there are companies, and you can easily buy a DNA testing kit, and it's growing so much, the matching services offered and so on, the databases are just growing so enormously. So yes, in answer, it is spoken of. And most of the time, from my experience anyway, people are perhaps aware of it, but haven't actually thought, right, okay, so there's actually a very easy way of potentially finding out who our donor is, who other half siblings are, etc., etc. So yes, it is very strongly emphasised.
Does anyone else want to come in on this one? Lee, I'm guessing it's something that you must have to cover as well with the donors in your clinic.
Yes, definitely, and it's definitely part of our talk with patients. With the genie's out of the bottle. There's DNA testing. People are giving these ancestry DNA testing as gifts, and they are revealing brothers and sisters of donors that may have nothing to do with donation, and they're being found. And you put that into context with social media and the networks and the webs that come up from that. It doesn't take a rocket scientist to know that it's very easy to be revealed. So it's very much part of our counselling service, and it's very much part of the conversations that we have. And if a donor hasn't considered that fact, that just further emphasis on the point that they need this implication to be prepared for that thought that they might have decided to do anonymous or unknown donation, but that might not be absolute, and that might not be forever, and that might have implications for their children or their parents or their brothers and sisters may be contacted in that context. So yeah, definitely.
Jacky.
Yeah, can I just add as well that developmentally, young people often go through periods where they're questioning their identity, and they could, just because they are absolutely sure they don't belong in this family or they think they've been adopted, use those kits at a really sensitive time in life. And so there are implications for just anybody of finding of discovering things that you just didn't know. And I think that critical time period, we also have to think about that when these risks are elevated.
Absolutely. I can remember my distant teenage years, and my best friend and I were convinced we were adopted, and if we'd have had, you know, the thing that is available, the things that are available now, we'd have been off there looking for some clue to for some more exciting life than our parents, who we considered to be incredibly boring. But you know, that is, you know, it's a part of development, isn't it? And you grow out of it usually and think they're actually pretty decent. A question from Laura Bridgens, which is, it's not just infertility expertise that's required, it's expertise on the donor-conceived experience. How can we ensure that implications counselling sessions are robust enough at the point of intention of using a donor? The industry is woefully short-sighted in regard to the donor-conceived experience. Who wants to take that one first? I think we'll perhaps go to Lee first as the donor coordinator.
Well, I think, as I identified in my presentation, as in the clinic, we're looking down a very fine lens of what is a bigger situation, and a donor-conceived child does fortunately have rights these days, and long are the days, or gone are the days rather, of anonymous donation. And there is this big situation where donors need to be prepared that one day their donor might well knock on their door. And it is how they perceive themselves whilst you're preparing them, or the counsellors are preparing them along with everybody else, to understand that they may be told at one point, and a child or a baby, as patients are looking for, becomes an adult and an autonomous human being with their own thoughts and ideas. And if you want them to be well-rounded, and if you want them to feel comfortable in their self and have high self-esteem, then openness and honesty is the key to that. And if you're delivering open and honesty from the clinic and explaining what can happen in the future, then you're halfway there to hoping that you get things right. But there's no guarantee. There's no guarantee that whilst in the clinic, a patient will tell you that they are up for this. They'll go to the donor conception network. They'll open the conversations very early in a child's existence, and they may well not, and we don't know. But I just think that we have to feel that we've done our job to the best of our ability and given them the best understanding, and back that up with evidence and research that shows that a donor-conceived child is a much happier individual as they go through their life if they understand their origins, and a much better individual place to accept that at an earlier interval in their upbringing.
Anybody else want to come in, or I will move on? I can't see any takers. Oh, sorry, Angela.
No, I totally agree. I think it's very difficult sometimes. I mean, we all obviously speak about what recipient parents are really thinking about what it might be like to be conceived. You know, sometimes, you know, ask them, what do you think it would be like if you were donor conceived? There is quite a donor conception network, fantastic. I mean, the workshops that they run are a great aid, and always mention those and implications as well. The We Are Donor Conceive website is also, I think, a very insightful resource. You get a lot of insight into donor conceived people's experiences, and they did a very interesting survey. I think it was maybe 2 or 3 years ago, but that is a good website. We Are Donor Conceived. It is that there is a real maybe lack of there's always need for more research in terms of the donor conceived person's experience, for sure.
And I think that ties back as well, Angela, to the points you were making in your presentation. You could call it continuing professional development, about the importance of going to some of these meetings and hearing from donor conceived people or intended parents 30 years on, etc., so that it then informs your practice when you're doing these implications. I think it all ties together. So I was going to go next to a question from Anne Chen, who is a fertility counsellor over in Dundee. And so she says some of the research results shared tonight show the variations in the counselling provision and services being offered. The evidence also clearly shows there's a need for fertility counselling. How might we improve the provision and availability of counselling within the UK? So there's an easy one to fix. I think people have been trying to do this for yet. But any top tips from the panel? Let's go first to Jacky. What do you think?
So the question is, how can we increase provision
and availability? Well, no, she's not said uptake. Someone else has mentioned uptake, so I might come to that. But if you wanted to roll uptake in, I think you could, because that can come down to the offer. Is like, and I think the point that person was making is like, oh, do you need counselling? If you ask it like that, then it's like oh no, I don't need counselling response, isn't it? So.
I've always argued that patients need different resources at different times in their experiences. And sometimes the thing that's really would most suit their needs would be counselling. And at other times, something else would most suit their needs. For example, simple coping interventions that they could download from somewhere, or what they would need is for their doctor to be trained in sharing bad news or something like that. Well, I'm not saying doctors aren't, but specifically for fertility care. So I think that the way to increase provision and to increase uptake even is to have a greater breadth of possible interventions. And returning to my earlier point, I think that was one of the great things that the HFEA did, was saying, do patient support and do infertility counseling. But I think more resources could also feed into that.
Good. Lee, what would you do if you had the magic wand to transform this?
Well, I work in an NHS hospital and I serve 3 masters. I serve the HFEA, I serve the NHS, and I serve Scottish Government, who actually fund my role. And what I would say, and this might be contentious, is if our NHS hospital can prioritise counselling and find the funds for a counsellor attached to our unit, then how can't the private centres? And I'm not saying that all counselling is unlimited, but I feel that counselling, the importance of counselling and enough sessions to get through something like implications should be offered, and money could be found if it was prioritised, and that might mean that certain other parts of treatment may need to be scaled back to make that provision.
Anybody else want to come in on that one? Angela or Alison? Okay, so we're getting towards the end, so I'm just going to have a quick look to see whose questions I've not asked rather. So a question from Sarah Patterson says, could a counsellor with over 30 years experience of raising donor embryo children be considered as having required competence to work in fertility with fertility clients? And then she's added a bit more further down, but keep jumping around. To add to my comment, a counsellor who is fully trained in BICA policy and training. So did you get that? Perhaps, Angela, perhaps you could answer that one.
I wasn't quite sure. I don't know if I was understanding the question very well.
Sarah's asking, could a counsellor with over 30 years experience of raising donor embryo children be considered as having the required competence to work with fertility clients?
Well, my goodness, that's someone who has had experience, very relevant experience for sure. Counselling in this person is a counsellor in a different sort of setting, not in a fertility setting at present. I would imagine, therefore, you would take yourself forward and maybe become a member of BICA, go through your foundation course and train your way through that. But my goodness, the extensive knowledge and understanding that you would bring to the role because of your experience of parenting donor conceived children would be immense, I would have thought. I don't know if that's answered the question though.
Yeah, I think, okay. I think we'll move on from that one. So there's one from somebody who's anonymous saying, would nurses delivering information, and then they put in scare quotes, counselling to patients, the HFEA counselling offer? Would that be, I suppose, proper counselling? I don't know who wants to go first on that one. I might go to Alison as somebody who used to be a fertility nurse.
Thanks, Sarah. So I'll answer it with fertility nurse hat on. I've got so many hats swirling around here. Many years ago, in 1986, nurses did do implication counselling because we did recognise at that time that there was a need for it. And implication counselling, I think, can be undertaken by nurses. However, it's on a different level to the counselling that a counsellor would undertake. The counsellor can use their skills to explore issues as and when they came up. I think that nursing staff can have a bit of training, and quite a lot of nurses do some person-centred training through the SING group. But there's courses run every year in conjunction with BICA to equip them with some skills. But I think sometimes, and I'll have to bounce back to Angela a little bit, as to how often implication counselling can trip over into therapeutic counselling. And I think also Lee mentioned the number of sessions that are available, because we often think implication counselling, off you go, see the counsellor for implication counselling, box ticked, one session. But that's not always the case, because as you start unpacking issues and look into future and trying to think of the long-term future, that's not always available in an hour. So in answer to your question, I think nurses could take some of the issues, but not all of them. And I think a bit of training would need to be put in place for implication counselling. I didn't answer the question at all.
I suppose it could come back to that sort of definition that I was talking about in my introduction, actually, that the nurses could do some of the role in terms of providing that sort of information, that so people go into the counselling with that information, then with the opportunity to explore what they are, because obviously, what the implications are in more detail into their particular set of circumstances, which can be very different, and to sort of speculate about what their future circumstances might be, I'm guessing.
Yeah, and I think that's actually a team role, because obviously, or not obviously, but very often implication, the medical consultation is where the first discussion starts about the options for reproductive health, whether you are going to consider donation, and that's the starting point to think about implications and let the patient immediately be made aware of the implications that can then be picked up by the nursing team and perhaps lead on to counsellor. So I think it's not just a one hit that's needed. It could be a whole team involvement.